With me today is Dr. Ferew Lemma. He is Special Advisor to the Federal Ministry of Health. Over to you, Dr. Lemma.
Thank you very much. Hello, everybody. Good morning, good afternoon, good evening. I'm going to present you about CMAM in Ethiopia. As you all know, we have been engaged in this kind of workshop a lot, so I'll share with you where we are and what we have done. To give you a brief profile about Ethiopia, you know Ethiopia is in the East Africa region of Africa, and the population is the second highest in Africa and has been growing by 5% annually. As you see, we have a stunting rate of around 37%, which has reduced by almost 30% since 2000, and a wasting of 7%, which has also reduced in the recent 3, 4, 5 years to 7% from 12. And you know, the infant mortality has also reduced quite a lot. It has been 55% and has been for a long time over 100 per thousand live births. So Ethiopia has quite a big area, 1.2 million square kilometers, and has 3 agroecological zones: agricultural, pastoralist, agro-pastoralist areas, which have different access. In terms of CMAM and the history of CMAM in Ethiopia, Ethiopia actually is one of the countries that started piloting or doing CMAM at country level in the year 2000. And due to emergencies and others, I think there was a large expansion together with the support of the UN as well as the international NGOs. And we developed throughout the years various national protocols. And the first one came out in the SAM case management in 2007, and also included the outpatient management of severe acute malnutrition. These also developed very fast, and was in 2008, the overall task shifting to our community health workers, also known as health extension workers. It was done quite early in 2008. And this was because of the health system started in 2003 and 2004, having health extension workers, which are mainly females, educated until 10th grade, and they were engaged in delivering services at village level, at community level, using a health post. And there are, in each village, we have 2 health extension workers that deliver services. And the package was included in theirs, and the rollout throughout the country has started expanding, and we use until 2010, and we used to cover 250,000 children were treated for SAM quite well. And based on that, I think we shared the experiences in the 2011 CMAM conference, which was held in Ethiopia. And we shared the experiences as well as learned from other countries from Africa and Asia about the CMAM and integration and within the routine services and how people could do about it. And also there are a lot of learning journeys or experiences among countries that happened during those times. Throughout the years, where are we now? I think service has increased, service availability in terms of geographic coverage has reached for SAM treatment about 95%. But in terms of service coverage, it's a bit lower. The whole program in managing moderate acute malnutrition is a bit less. It's around 25%, and this mainly focuses on highly food insecure areas. That's why it is only very low. But recently, at the end of 2020, we have started from 250,000 to 500,000 children reaching SAM children, which also recover more than what is given in the sphere standard. We also reached around 2 million pregnant and lactating mothers, as well as children with moderate acute malnutrition now. So that is the whole picture of how CMAM has developed throughout the country, as well as the services have changed. what were some of the things we adopted? The main thing was simplification in terms of the referral as well as identification of wasting, particularly using MOAC by frontline health extension workers. This was started early because of the availability of equipment as well as several capacities. Health extension workers used MOAC to diagnose and treat very well. Also, there are a lot of adaptations made within the package of what is delivered using the CMAM package that included antibiotics, which were usually given without any prescriptions. And we are also currently investigating what could be more simplified, but this will be covered more with my colleague who will present the Ethiopian case study in the coming days during this conference. And some of the areas which also need to focus is I think we need a very good integrated work with partners, the UN, civil societies, as well as the government. And there is quite a supported and impressive coordination and sustained support throughout the years with the global network as well, in terms of managing how to go about the adoptions and as well as strengthening the existing system. The supply chain management is also one thing we need to look at when you are trying to strengthen the governance. It needs to be covered because supply chains quite affect our quality of services and how our reaching a lot of children at the right time, at the right moment. And there is also a need to use the frontline workers, but we need to develop their capacity continually. And we do these in Ethiopia every year or biannually, usually using the integrated refresher trainings for health extension workers or community health workers, and also look at new developments and update your guidelines, as well as look at the supply chain resources. And while we are doing this also, we need to have a monitoring system that will help us see if the quality of services are there and if we are reaching the right number of children and we are continually doing the services through. And our monitoring system is built in within the existing health information system. And we are currently using also the DHIS2, which also helps to look at how the services are being delivered and the quality of services. But also even during this current pandemic, we have included the government, because of its leadership, has included the CMAM indicators within the essential health service package during COVID pandemic. So what are our key learnings? I think when we start, we need to have a good to convince the government so that there is a commitment and ownership, and that our existing system could use the frontline workers, the primary healthcare units, to deliver the management of some cases, and also use our frontline workers or health extension workers that could easily identify, refer, and treat some cases, which is true in our country. And those needs to integrate within the commitment, the system, but also our frontline health workers need to be updated continuously. The other issues which will also has affected a lot of countries is the supply chain, because it's not easy to the logistics and supply chain system needs to be strengthened, and what is needed for scaling up CMAM are quite big, as well as the volume per case is also very large. So there needs to be, we will need to look at before scaling up how the supply chain and management system will cover what we need to deliver. And I think in terms of coverage, I think we need to sort of look at the scale up to reach a large number of children, because there are, as I said, different agroecological zones which have different modalities, and we need to look at how we are going to do the CMAM work in a pastoralist area where there is quite a high level of moving around. So our main challenges, or going ahead as well, is I think we need to, besides the CMAM, I think we need to focus on what we need to do to prevent, particularly because wasting also has a high contribution to stunting, and also the coverage you have now, as well as the CMAM services before children are severely wasted, need to be addressed. So I think focus on strengthening the prevention activities within the country is necessary. And I think there is a lot of unpredictable emergencies. For example, we had last year flooding as well as desert locust, and then a bit of displacement. And so we need to look to be prepared to respond to these kind of actions. And going ahead, there is resources, manpower is a place we need to think over, and our health extension workers are nowadays being developed because we have developed a career structure for them, and most of them have now gone through, have a diploma as well as a career structure. So the staff turnover needs to be addressed to continuous capacity building and others. So that's another area which might be a challenge. And also, when you are looking at, or I think globally, there is a look at what we can do in terms of having developed a new product or a local product. So that is another area that we think could be a challenge because of supply chain, resources, and commitments are quite necessary here. I'll stop here. Thank you.
Thank you very much, Dr. Ferew.